Welcome, everyone. Thank you so much for joining us today. My name is Lee Clark, the Senior Director of Patient Programs at the Aplastic Anemia and MDS International Foundation, and I'd like to welcome you to our first 2026 webinar, which will be about the 2025 ASH updates on aplastic anemia and PNH. Before we get started, I'd like to thank our diamond level sponsor, Apellis, and the generosity of our patients and families and caregivers who, without everyone's support, this program would not be possible today. Immediately after the presentation, there will be a question and answer session. In order to submit your questions for our specialists today, please use the Q&A icon in the bottom part of your screen. Just push the icon, type in your question, and then we'll get to everyone's questions at the end of the presentation. I do ask that you do two things to help me manage the incoming questions. First, please submit your entire question all at the same time. You can submit multiple questions. And then second, please do not provide personal information about your healthcare. Our specialists today cannot answer any specific questions related to your personal healthcare. Our specialist today is Taha Bat. Dr. Bat is an associate professor in the Department of Internal Medicine at UT Southwestern Medical Center. He is a member of the Division of Hematology Oncology, and he joined UT Southwestern in 2020. He specializes in bone marrow failure syndromes, PNH, PRCA, aplastic anemia, and LGL. It's my pleasure to welcome Dr. Bat.
Thank you so much, Lei. It's a wonderful to be here again, and I'm gonna share my screen just to go over some of the important findings that was presented at ASH today. Let me do this. Another way of sharing. So it's wonderful to start off the year with the ASH updates. And this gives the wonderful message to our patients that AMDS is pretty much devoted for the life of our wonderful patients. And they are putting these efforts together to make the patients being updated from the most recent important information. So thank you, AMDS, and thanks for the sponsors for making this event possible. And so again, my name is Taha. I'm a full-time father, but I do also see patients here at UT Southwestern for the aplastic and PNH and marrow failure disorders. I think this again showing the other way of, all right, let me do this. Sorry, complicated. I'm not a completed person, so
That looks good.
Yes. All right. So everyone is able to see my face, right? The slides, correcto?
It looks wonderful. Thank you, Dr. Bat.
Okay. Thank you so much, Lei, again. I mean, I'm gonna keep it very short, right? Hopefully it's gonna be short. And then I want to get some questions, right? I'm not here to go over what healthcare professionals to learn, but I will go over some of the updates. But at the end of the presentation, there will be two slides that I, highlighted the summary of ASH 2025, right? Everything about aplastic, everything about PNH. But this is what makes me happy, not the presentation. Question and answer session makes me more happy, and it makes more patient-centric answers rather than my silly presentations. So again, my name is Taha, and I'll go ahead and get started before wasting any time. This is my disclosure. So there will be two separate abstracts that I will talk, right? Or the updates. So the first one is going to be more covering the aplastic anemia, the first maybe 5 or 7 uh, slides. And then after that, I will be going over the PNH, the updates from the PNH, a lot of updates, a lot of good stuff. So I'm so excited to make this, presentation very informative for our patients. So the first study that I will go over is presented by the European group. So basically, I'll explain to you what does it mean. When it comes to aplastic anemia patients, we know how to treat for severe aplastic anemias if they are age appropriate and they have a sibling donor. We usually go with a transplant. If they don't have sibling transplant or they're relatively older than 40, then we don't, offer them a transplant in 2026. And when it comes to moderate aplastic anemia, that means non-severe, that means they are not meeting the criteria for severe aplastic anemia, then the treatment has been, uh, some guideline was recommending watch and wait, some guideline was recommending the cyclosporin, but this long, phase 3 trial showed very promising results treating those moderate aplastic anemia patients with L-Thrombopag and cyclosporin. So again, the presentation was done by Hubert from the European group. So basically, this is a phase 3 trial, randomized placebo control. They enrolled any patients who was meeting the criteria for moderate aplastic anemia, and they were all treatment naive. And basically, whoever met that criteria, they enrolled this patient population and they treated the patients cyclosporin with placebo or cyclosporin with L-Thrombopag. And the primary objective of this study was assessing the response by 24 weeks. So you can see here how the schema, how they stratify the patient 1-to-1 to cyclosporin L-Thrombopag or cyclosporin placebo. And they looked up the response rate at 24 weeks, right? And most of them were moderate patients, and they had a platelet count ranging from 12 to 20s, right, in each group, or from 18 to 30s. They were not uh, uh, I would say not all of them was requiring transfusion dependent, right? So 27% or almost 1/3 of them was requiring transfusion. And you can see here at 12 weeks and 24 weeks, the patients were treated with L-Thrombopag plus cyclosporin had better overall response compared to the cyclosporin alone, combined with the placebo. And also at 24 weeks, you can see here, the overall response was 70% on the L-Thrombopag plus cyclosporin arm compared to the placebo plus cyclosporin. So it clearly showed benefit of using L-Thrombopag in addition to cyclosporin on this moderate aplastic anemia patients. Later on, after 24 weeks, they allowed anyone to cross over into the arm of L-Thrombopag to make sure that they are also getting the full benefits. When they assessed them, they did show increased complete response and better partial response on the patients who were treated with cyclosporin and L-Thrombopag that were not initially assigned to the L-Thrombopag arm. And you can see the cumulative incidence of that response on the L-Thrombopag treated arms, even they crossed over after 24 weeks of treatment. So they basically concluded this L-Thrombopag combined with cyclosporin should be the preferred initial treatment for patients with moderate aplastic anemia and should be the new standard of care for non-severe, means moderate aplastic anemia patients. And again, these agents are pretty easily tolerable at outpatient setting, right? They are not as harsh as the horse ATG, right? And it showed clearly it's benefiting for transfusion recovery, for platelet better response. So I think that made very good standard. So the second study that I want to discuss is very interesting, right? And this is a very interesting because not, as we know, some of our severe aplastic anemia patients will not be a good candidate for allotransplant, right? Even they are refractory, even they are relapsed, they will not be eligible. Why? Because of the GVHT, right? And so the group from NIH, and I'm proud to be trained by him years ago, Richard Childs led this efforts. They basically enrolled refractory and relapse aplastic patients to use this very novel technology. It's called umbilical cord expanded stem cell population. So they basically use this product to give to this refractory relapse patients to treat their aplastic anemia. And you can see here, they enrolled, I think, 19 severe aplastic anemia patients, and very similar to transplant workup and transplant regimens, right? They used some conditioning regimen to get rid of your old stem cells, and they give some transplant needed, radiation before the transplant, and they transplanted this OB2B cell. It's called OB2B cell, umbilical cord blood product, and they treated the patients after this infusion with the tacrolimus and mycophenolate to prevent any further chronic GVHTs, right? Very simple. And look at this beautiful graph. No chronic GVHT. No chronic GVHT. There was no severe acute GVHT neither. And this patient population, age was not too old, but remember, if someone does not have chronic GVHT complications, even for 5 years follow-up, that's phenomenal drug, right? And this overall survival was 94%. And the neutrophil recovery was very short. Normally, umbilical cord is not the favorable transplant agent. Why? Because it takes forever for the neutrophils and platelet to recover. But look at the median time, median days of neutrophil recovery, just only 8 days. And so basically they established this product to be used for any refractory or relapse aplastic patients. The problem with this agent, and it's also FDA approved, the same day they presented at ASH, it got approval from FDA. So the problem with this drug or this regimen is not every institution will offer this treatment. Why? Because not every institution have the ability to use the umbilical cord products. So in the very near future, because FDA approved now, in the very near future, each one of the centers will start offering this treatment. But please, as a patient, bring this up to your transplanter. Bring this up to your hematologist. Hey, Dr. Bat, or it doesn't matter, Dr. Bat. I was in AMDS Foundation talk, and someone from Texas gave this talk of umbilical cord expanded stem cell population for the transplant. Am I eligible for that? Okay, please remember this. So this is phenomenal medication, and we will hear more. Hopefully, once they will submit this as a peer-reviewed journal, we will see more details of this study. But overall survival in 5 years, 94%, is quite remarkable for this very poorly treatable disease. So again, just to recap for aplastic anemia, right? I love aplastic anemia disease, and this is what I'm trying to show everyone. This is severe aplastic anemia treatment, right? We treat with transplant. If you're not transplant eligible, then horse ATG, cyclosporin, L-Thrombopac is the first choice, right? We assess the response at 6 months. If you are responding, awesome. Just keep going with your cyclosporin up to 2 years, and then you can discuss with your hematologist for continuation of L-Thrombopac or cyclosporin. If you are not responding, don't wait in your home. Please go and ask your hematologist, hey, am I eligible for Campath? Am I eligible for tacrolimus? How about rapid ATG? if someone is not responding, the other treatments are the transplants, right? Match related, haploidentical, or the OB2B cell, the one that I just went over, right? And so what I want from each one of our aplastic patients to do, don't say I'm done because I'm not responding. That means I will be getting the transfusion for the rest of my life. That's not true. Look for second opinion. Please look for second opinion. Don't stuck to your local hematologist. Go to Hopkins, come to us, go to Mayo, go to Cleveland, go somewhere that they will offer you some second opinion. Okay, please, this is very important because I see a lot of patients and they will have a delayed second diagnosis for years. Don't do that. And remember, this disease is a long-term journey. Make sure that you are being followed up, especially if you have a PNH clone, if you have a PNH clone positivity, because that PNH clone can be expanded and that can transform into the PNH disease. So make sure that you are following and asking about questions. Hey, I had a PNH clone years ago. Are you monitoring that, doc? I just want to make sure because someone said that clone can expand. Okay, so don't forget that. So now let's move to the PNH updates part and talk about a little bit about PNH. So what's PNH? I don't have to go over it. A lot of discussions, but remember, it's all about alternative pathway related abnormality where your body will destroy your red cells. Okay? Very simple. Normal general population, physiologically, this process will be abolished because of the some of the red cells, some of the red cell receptors that we have as a non-PNH people. But if you are PNH, that means some of your red cells, some of your platelets and white cells do not have some receptors to protect you from the C3 convertases. In that way, your complement system through the alternative pathway will be accelerated, and that will lead to red cell destruction, and you will have hemolysis, and that is called PNH disease, not PNH clone, PNH disease. Okay, so uh, let's go over this. I will come back to this one. So I will give you a couple updates that was presented at ASH, and I will go back to our phenomenal algorithm for PNH treatment. So this study was presented by Chinese group, Heng Li, I think Guang Heng presented the study. Basically, they've introduced another complement inhibitor into the world of PNH by combining C3 inhibition by the C5. And they presented the phase 2 results of this study. As you can see here, I just showed you the complement cascade. C3 and C5 involved destruction processes. And this new drug called LP005, I think the brand name is inhibitor, basically inhibiting the C3 and also inhibiting the C5. So it's bifunctional inhibition, right? And they only enrolled 10 patients for each arm. This is an IV and it's given every 4 weeks. It is an IV medication. It's given every 4 weeks, right? And they enrolled, a classical PNH patient population with the hemolysis signs, and they looked up these people up until week 24 to see if there is a good benefit of using this agent, right? So you can see here the most of them was hemolyzing, not most of them, all of them was hemolyzing, and some of them had the aplastic anemia component as well. And you can see here the benefit of 900 or 1200 milligram dose obtained right after a couple days of being introduced to this bifunctional complement inhibitor. And you can see here in the hemoglobin improvement how the people responded to this drug. Obviously, they enrolled only 10 patients, right? So we're not going to jump into this treatment at the moment. We have to see more patients, more years, right? And then the side effects wise, very well tolerated. As we know, being on complement inhibitor makes you susceptible for infection. That's why we keep you on antibiotics. That's why we give you the immune vaccination to prevent any encapsulated bacterial infection. But even we protect you, you have to protect yourself when you go to crowded places, because we cannot protect you from all the bugs around us, right? So you have to keep in your mind, even you're vaccinated, put the mask on it when you are in the crowded places. And you can see the results, the benefit of this drug. Every one of the patients who enrolled to this drug became transfusion independent, right? So that's good. So basically, they showed that this drug is another novel monotherapy, can be used to block two different complement pathway, and can be another treatment option in the near future, maybe 2 3 years, for the PNH disease. And now I will move to another study that was presented by the University of Leeds group, and they showed benefit of adding danicopan into the PNH patients who were treated with ravulizumab or C5 inhibitors, right? So because they already established the benefit of danicopan, right? But they wanted to assess the benefit of this drug for in the elderly patient populations, right? So again, same. There is nothing special on this. They evaluated the people who treated with danicopan additional to the ravulizumab, and they looked up if they were tolerating the medication as well as the young patient population. So you can see here, the patient volume was very low again, right? Only 16 patients on the danicopan arm, but for the most part, they did as good as young patients when it comes to transfusion independency, when it comes to controlling the LDH, right? And you can see here the age was not a criteria to say you will not get the benefit from danicopan. And the adverse event, because one of the problems that danicopan is hepatobiliary, headache, right? They did as good as young patients when it comes to side effects profile. So they did well with no concerning side effects for additional danicopan in the elderly patient population. And they concluded danicopan is safe to be used after the age of 65 if you need danicopan. But there is a caveat of using it, right? Danicopan is 3 times a day. You may be missing, so your compliance is big deal. If you're not compliant, please make sure that you are addressing this with your hematologist. So now what time is it now? 2:24. That's great. So I want to finish everything in 30 minutes. So we have another 6 minutes to finish, and then I will spare 15-20 minutes for the questions. So some updates, right? What we went over. I have 2 slides to go over the updates. This is the first slide because I went over the studies. Again, cyclosporin L-Thrombopac is effective combination for moderate aplastic anemia. Correct? Yes. Second important update is obidubicel. Even it's very hard to pronounce, and it's not well-known medication as of now, is a potentially effective transplant for severe refractory relapse aplastic anemia patients. Okay. Number 3, LP005, the one that I went over the slides, agent is newly developing agent that blocks proximal and terminal pathway at the same time by getting the IV, infusion. Number 4, danicopan is safe agent for patients older than 65 with no concern of safety profile. So these are the other updates, right? And I want to go over them very slowly, right? And I want you guys to understand and bring the question back here. Good part of having more factor B agents, what factor B agents do we have? Right now, we have Fabhalta, correct? Yes. The Fabhalta is only factor B agents that we are currently using. But more factor B agents are coming. So it's good because each company has to lower the cost, right? So it's good for our patients, good for us to be able to prescribe these medications in the developing countries. So I'm so glad more companies are producing more factor Bs to be used for PNH. But remember, we need more years to be able to use those agents, especially after the FDA approvals. Number two, real world evidence of being of benefit of being, I'm sorry, real world, there's a great real world evidence that every PNH treatment that has been FDA approved that is good enough to control your hemolysis, right? Every one of them, okay? So I will go back to this slide because I messed it up. That was my plan to show you this slide. These are all the complement inhibitors that is being studied for the disease of PNH, okay? The bold ones are the ones that has been FDA approved. Iptacopan, danicopan, in addition to C5 inhibition, crovalimab, became epicically pegcetacoplan. These are the FDA approved medications for PNH. That's great. But more drugs are coming, as I said. And each one of this FDA approved medication, iptacopan, pegcetacoplan, danicopan with additional ravulizumab, crovalimab, they are all very promising agents for your PNH disease. Okay? So let's make it very clear for every one of our patients to understand this, right? Be happy what you are on it. But if you are not doing well on one agent, I mean, common sense. You need to ask your hematologist. I'm not doing well on this, dude, doc. I mean, this is giving me transfusion requirement. This is giving me a clot. This is giving me a problem with compliance. This is giving me a problem with infusion. So remember, each one of them is very effective. Each one of them breakthrough hemolysis is slightly similar. Their mode of administration is different, right? One of them is IV, one of them is sub-Q, one of them is pound, one of them is oral. And then frequency of administration, I mean, and then safety during pregnancy. So those are the, points that you have to bring this to your hematologist attention. So we'll keep going with the summaries. Real world evidence, I went over that. Continuation of anticoagulation, even being on complement inhibitor, is useful. What does it mean? If you had a Budd-Chiari, if you had a retinal vein occlusion, if you had a intracranial, some sort of stroke, being on blood thinner, anticoagulation or antiplatelets is useful. Okay, don't discourage yourself by saying, "Oh, I'm on complement inhibitor. I don't have to be on it." The data is not clear, so make sure if you had the severe clotting issues before you started the complement inhibitor, bring this up to your hematologist attention. Hey doc, do I need to be on complement? I'm sorry, do I need to be on anticoagulation? Because one of this Texas guy said you need to be on anticoagulation. I just want to make sure, right? Number four, changing among the complement inhibitors are very normal. If you started on one medication and you are not doing well on it, please don't say I have to take this transfusion for the rest of my life to kill myself. No, ask your provider. Ask for second opinion. This is what we do. This is what we do. We are here to help. We are not here to make money or any stupid nonsense. We are here to help. So come and ask and email. We are happy to help. Number five, complement inhibitor treatment are safe from infection standpoint in the pediatric population. So that's a great news, right? Because you will be concerned they have more susceptibility for infection. No, it has established at this ASH. It's pretty good, right? Number six, iron removal is important treatment of PNH. What does it mean? By the way, these updates are not something that I, wrote it because of the last 20, 30 years data. Each important point is presented at ASH. So iron removal is a key treatment for your PNH. What does it mean? Bring this up to your hematologist. Hey doc, do I have a ferritin being elevated? Do I have to be concerned about iron overload? Blah, blah. Let them to judge that. But if you will not remember and if you will not remind them, 90% of the time they will forget. Okay? Doesn't mean your doctors are wrong or everyone is so busy, and sometimes this iron chelation, iron deposition, iron overload can be missed. So bring this up just to be on the safe side. This is what AMDSs do, right? We are advocating for our patients. Number 7, there is a good signal to use ravulizumab in pregnancy. So it's great news. Maybe in the very near future, once we have the publication in the peer-reviewed journal, and hopefully I'll bring this up next time. Hopefully, if the publication will be there, maybe ravulizumab will be used. I know some of our patients are already using ravulizumab because they are not doing well on eculizumab, and so there is a good signal that they present at ASH that ravulizumab hopefully is going to be appropriate for the pregnancy by the guideline recommendations. Number 8, this is especially important for our aplastic patients. There is an increased cardiovascular disorders among aplastic patients. What does it mean? Make sure that you are keeping up with your lipid panel. Make sure, and this is especially important for our PNH patients because thank God every one of them living so long, right? They underestimate the cardiovascular events when it comes to clonal disorders of PNH. Make sure that you're asking your primary care, hey, doc, do I need to be worried about my lipid panel? Do I need to be on statin? How about do I need to do anything special? Keep yourself active, especially once you become transfusion independent. Don't wait for the normal age comparison. Just go back to your norm and walk and jump and joggle. Do something to lower your cardiovascular risk factors. I think that's pretty much it. This is what I gathered from ASH 2025. It was overwhelming. It was exhaustive, but I think that covers most of the things that was discussed at ASH in 2025 annual meeting. And I'm happy to get all the questions, Lay, that our
Great.
patients.
Well, thank you so much, Dr. Bott, for the wonderful presentation and everything that was presented at ASH. So we have a few questions. Our first question is, thank you, Dr. Bott, for always answering our questions. So for this question, how do you manage your patients who lose good responses when cyclosporine and Promacta are weaned?
Yes, that's a great question. Very simple. Again, repeat your bone marrow biopsy. Make sure it's not the MDS or evolving MDS. That's number 1. Number 2, if you are still aplastic anemia, look for other causes if you are relapsing, right? If you're refractory, even then you have to look for other causes. Number 3, you have to be starting cyclosporine and L-thrombopag at the same time. Don't waste your time by just being one agent. Double agent works better. If you are not responding to cyclosporin, as I went over, tacrolimus is the agent of choice. There has been a lot of data. Tacrolimus, especially women and after certain age, works better. So make sure that you're asking this question to your hematologist. If you are not responding to cyclosporin L thrombopag after 3-4 months, what are you gonna do? Second opinion. For what? Transplant? What's my option? Do I have a proper diagnosis? What do I need to do? Don't say I have to be on transfusion dependency for the rest of my life. Please bring this up to our attention. I'm happy to answer all the questions that you have. Email me. I'll answer it. So I hope I answered the question.
Thanks, Dr. Butt. Our next question says, if you're an aplastic anemia patient, has LDH in the normal range, hemoglobin is around 90, and a PNH clone of 23%, is it okay for a patient to watch and wait and have clone size monitored every 3 to 6 months versus being on treatment?
Yes, that's a great question. The clonal size matters. Clonal size matters. If you are not having dark urine, if you are not having fatigue, if you are not having PNH episodes, that 23% clone may regress. Don't be on complement inhibitor. Don't. Okay? that clone may go down and you may get rid of PNH. What does it mean? Be very cohesive with your hematologist. Let them to check your PNH clone on a regular basis, your LDH, your hemoglobin. If it is going up 40, 50, and your LDH goes up, there's a risk of clotting. You don't want to wait. If LDH goes to 700, 800, start on treatment because LDH is very important in addition to D-dimer. Ask your hematologist, do I need it? Don't treat numbers. Treat disease, treat PNH disease. So clone may regress. I have several patients, clone regressed. That means clone disappeared. They did not require any complement inhibitor for the rest of their life. Isn't that nice? So being monitored, close monitored, crucial. That's it.
Thanks, Dr. Bott. Our next question, it says, on your key update slide, what are the types of increased cardiovascular disorders among the aplastic anemia patients?
Stroke, TIA, heart attack, arrhythmias. The full publication is coming soon, but these are the four ones: stroke, cardiovascular problems, including heart attack, arrhythmia, and TIAs.
Thank you. Our next question is, could you elaborate more on what is safe for pregnant women with PNH in terms of treatment and safety for baby as well, or pregnancy is dangerous and what other options should be explored?
Pregnancy has its potential to be risky, but being a mother is everyone's desire, it can be everyone's desire. So we have to respect and we have to manage. We cannot abandon anyone from what they are willing to do. There is a good data using ravulizumab, not eculizumab. I mean, eculizumab is already being used for PNH, but the problem with the eculizumab, it can cause clinically significant extravascular hemolysis. So you may become a transfusion dependent if you're on eculizumab, if you switch from ravulizumab. And so, as of now, you should ask this with your hematologist, local hematologist. If they are not helpful, look for second opinion. Second opinion doesn't mean your medical insurance has to be involved. Involve your email me, email someone who knows PNH, and we'll answer it. Ravulizumab has a good data to use. And we have patients on ravulizumab, and they do great. And so there is no safety concern for baby. There's no safety concern for mom. And hopefully in the very near future, ravulizumab is going to be uh, approved for the pregnant patients.
Thank you. Our next question is, at ASH, was there any new updates or findings regarding progression to leukemia and or MDS in aplastic anemia or PNH patients?
It's very vague question, but I can say this. Clonal evolution, that means, as you said, aplastic to MDS or PNH to MDS, up to 10% of the patients will have this unfortunate outcome, right? And so the question is, how can we predict ahead of the time to give them the benefit of transplant rather than waiting for the MDS to evolve, MDS to emerge? So as this ASH, there was no clear, updates, but there has been some studies that they're trying to do a machine learning models to predict these people ahead of the time to give them the benefit of transplant, because when you are being transplanted, you are abolishing that risk. Not 100%, but almost 100%. So transplant in the early settings is good. And there is a good data coming out very soon. I mean, it may not happen in a year, but it will happen in a 2-3 years. And we may be changing the aplastic anemia treatment. So we may be doing transplant for our aplastic patient, regardless of their age, regardless of their donor. Okay, so that's evolving, but very exciting to see that, improve a treatment landscape for aplastic anemia patients. So we may be not using horse ATG maybe in a 2, 3 years. Maybe we'll say, okay, if someone is not great candidate for transplant, then ATG is choice. Maybe we'll use transplant. Again, there's a good data presented by Hopkins group, but not this ASH. So hopefully next ASH we will have some data from the BMT group that has been studied on this transplant outcome for these aplastic patients.
Thanks, Dr. Bott. We had a question sent in ahead of time, and it says, regarding any updates for PNH treatments, have there been any reports of malignancies associated with the use of Fabhalta medication? And if so, what type of malignancies and approximately how many patients?
So, does anyone seeing who posting these questions?
This came by an email.
Oh, by
It's
email.
not in
Okay.
the chat.
Yeah. So it's hard to say. There is no data, and there is no data to say cancer is happening because you being on complement inhibitor. Up to 5 to 10% of PNH patients do have cancer diagnoses in addition to the PNH. But we don't know if it is PNH related or if it is related to cyclosporin exposure or if it's related to complement inhibitor exposure. So it's hard to make that distinction. So I would vaguely say there's no clear evidence complement inhibitors causing cancer. There has been so many concerns over the last 10, 20 years, and we have a retrospective data that up to 10% of PNH patients in the long term can have cancer, but we don't know if it is because of they are being on complement inhibitor or it's because of the PNH disease.
Thank you.
Yeah.
Dr. Bott, and to the person who asked this one question, there's a lot of personal
Sure.
information in this
Gotcha.
question. So what I'm going to do is I'm going to take this question and I'm going to email it to Dr. Bott,
Sure.
let him give a response, and then I'll follow up with the patient. It's
Sure.
it's a very long and there's a lot of personal information that I wouldn't want to share in a on a public forum. We and Another question is, to what extent is the increased cardiovascular disorders recommend diagnostic testing for obstructions or buildup of plaques?
Oh, I mean, again, this is the first report that came out. I think it's hard to allude on it because we don't know what each individual patient risk factors were. But I would say this, I mean, standard of screening is important. And I don't mean the if you have been taking care of your lipid, if you have been taking care of your weight and your mobility, you're going to have the risk of cardiovascular. But because of the transfusion burden that most of our aplastic patients do have, that itself is causing cardiovascular events. So again, being on transfusion is increasing your risk. Being on cyclosporin and any medication will make you to have further problems with your cardiovascular uh, uh, system. So what I'm trying to say, if you have a diagnosis of aplastic anemia, don't say that, oh, I'm cured from aplastic or I'm done with aplastic, my platelets are phenomenal. Don't leave it there. Keep going back to your normal life. Keep going with your physical activities and make sure the risk factors are being increased among the aplastic patients. So don't underestimate that. That's what I'm trying to say. I hope it's not confusing.
Well, that was all of our questions. So thank you so much, Dr. Bott, for sharing your time and your expertise with all of us today. And I know we have some other great meetings coming up that'll be later this year discussing other things with aplastic anemia and PNH, which would be at EHA coming up later this year. And we did have someone put in the chat, thank you, Dr. Bott. Well, thank you again. And if anyone would like to view this webinar again at a later time, it's going to be available on our website within 7 to 10 business days. We're going to be sending out an email, which is a survey for everyone to take. Please do take a couple of minutes. Let us know your thoughts regarding the webinar. It really does help us in making sure that we're meeting your needs and which webinars that we continue and others that we need to look at creating. On behalf of the foundation, I'd like to thank you for reaching out to us and always making us your resource of choice on information on bone marrow failure diseases. This concludes our program. Thank you, Dr. Bott.
Thank you, Lay, and we'll talk after that. So you said you'll
Yep.
set up some meeting. We'll talk at that meeting.
Yep. Have a great day.
Happy New Year. Thank you so much.
Bye-bye.
Bye-bye.